So, good evening, everyone. I wishing you all a very happy Holi today. And today, myself is Dr. Sunita Inge, and today is the second episode of Mahaiap Case Challenge. And it is usually held on the third Friday of every month. I welcome all the experts. I welcome Dr. Aarti Kinikar ma'am. She's an expert, all the team members, the moderators. I welcome Dr. Mohite sir, who is the brain behind this case challenge session. And I welcome all my colleagues. Dr. Gangolia sir is here. He's a MIP president. Sir, would you like to say a few words for his opening remarks? He's traveling and he's en route to Delhi.
No, he's in Mumbai only.
He's in Mumbai. Okay, he's at the airport. So would you like to say? Would you like to give the opening remarks?
The flight is delayed. Of course, good evening, everybody. Nice to see this episode of Mahaiap Case Challenge. It is a really very good thing to see, and all the best wishes. So I will invite our Vice President, Dr. Vinayak Patil, to give his remark first.
Yes, sir. Over to Dr. Vinayak, sir.
Thank you, sir. Happy Holi to everyone. I, on the behalf of Mahaiap, I welcome everyone for this today's unique session of Case Challenge. And this unique session of Case Challenge has been conceptualized by our own Dr. Mahesh Mohite sir, a great academician from Raigad, and we are proud of it. And of course, this has been very hit in every other platforms also, and I'm sure that on this Mahaiap platform also, this case challenge everyone is enjoying, and I'm sure that today's session will also be a very challenging and also very interesting as per the last event. And my best wishes to both the teams for this today's event. And we are fortunate to have Dr. Kinikar madam as a great academician, being expert for today's this session. And my best wishes to everyone. Thank you.
Thank you, Dr. Vinayak. Dr. Jay?
Yeah, good evening, everybody. Happy Holi. I will say happy academics to each and everyone. So with the day started with the colorful colors. Let us have colorful colors of the academics paddocks today only. And this Raigad IP started quizzes initially, and in that I think that is almost should be academics should be more of a interesting one. So it's another challenge for us. We know each and every patient coming to our clinic or OPD or ICU is a challenge for us, and it's very fantastic concept started by Dr. Mahesh Mohite, and it is well appreciated by all of us, and very much interested. And our Mahaiap wants to involve each and every patient from the Maharashtra as well as from the India. So all of you, best of luck for this beautiful. So you crack the case challenge. Team Aurangabad and team Sholapur, they are very well played in the last year's quizzes. And all the best to you. And over to Dr. Sunita again.
Yes.
Team Solapur is dear to Dr. Jay.
Thank you, Dr. Jay. So now I'll request Dr. Mohite sir to say a few words, please.
Yeah. Thank you, Dr. Sunita. Thank you very much for this opportunity. Dr. Aarti Kinikar, actually Naina Chawand, my registrar, a very Kadak registrar in those days. Darara hota madam ja tyaveli as a registrar. So I should recall that. And with that, just brief about what has been done. Actually, the concept behind this is not essentially to reach the diagnosis, but we want an approach. Because these many PGs will be watching this, so it's kind of a message given. Whether you reach the diagnosis or not really doesn't matter. What is important is from the clinical presentation, the history, the clinical examination, and maybe sometime followed by the investigation. We want some structured approach to be given to the next generations so that they can become much wiser than us. That's a basic concept. Diagnosis is immaterial. You may diagnose, you may not. We are not going to discuss the management at all. So let's get it right and let's start. Thank you very much.
Thank you, sir, for your inputs. Now I will. I'm here. It's a great honor to introduce our expert today, Dr. Aarti Kinikar, madam. She is professor and head of pediatric department, BJ Government Medical College and Sassoon Hospital, Pune. And Madam has an extensive teaching experience of over 35 years. As the Moite sir said that she was very Kadak person and very illustrious CV, Madam. She has been, her special field of interest has been child nutrition, infectious diseases, hematology, HIV, TB, clinical research, and medical education. And she has been recognized by John Hopkins Hospital, USA, as International Fogarty Scholar. She has received the Best Medical Teacher, Dr. Sharidini Dahanukar Award from the MUHS. And she has a tremendous research experience, and she's been a principal investigator for various clinical research trials. No wonder she has publications like 65 in international journals and 62 in national journals. Madam has also her sense for her knack for research and innovation. She has developed low-cost ventilator for which she has got patent for it. And she has received Avishkar Research Awards, not once, but thrice by Governor of Maharashtra. She is a national trainer for various Government of India national programs. And she is a chairperson of many committees. But I would like to mention that she has been in charge of Center of Excellence of COVID Care, H1N1, FBNC training, NRC, pediatric TB, and MDR TB. And she's been the member of the Maharashtra State Pediatric COVID-19 Task Force. And she is also the Secretary of Human Milk Banking Association India for the year 22-23. Madam, we would like to hear a few words from you.
Thank you, Dr. Sunita. I think you should not have read all those things. I just sent it for you.
But Madam, each and every is so important. I couldn't lose any of it.
Okay. At the outset, I want to thank Mahaiap for giving me this opportunity to interact with you all. And of course, Dr. Mahesh, he says that I am Kadak, but I wasn't. I had a lot of naughty residents, so I had to be Kadak with them. Just a second. So what he has described just now is very right, that you should know the approach to a case. At the end of it, if you are right, you are very happy. At the end of it, you think you have missed something. That's what you have to find, because you can't reach a diagnosis. And medical field is such that you may not always be able to get one correct answer or a diagnosis. And what we appreciate is the differential diagnosis which you give with justification. And in pediatrics, if you see, most of us will know that we are reaching the right path if we take a good history. 80 to 90% of the time, if a doctor has taken a good history, you will know what you are dealing with. The children don't like to be examined, so hardly they allow you to examine. You have to have some observational skills. So while you are interacting with the mother, you talk and observe the child also. And very rarely you need really some investigations in a child. As far as possible, you need to avoid it. It is mainly to confirm your clinical diagnosis. So all these three things put together, I should really congratulate Dr. Mahesh for starting this very apt approach, and the sessions. I think they are going to be popular. And in a way, it is an exam for the expert also, I think. So he's taking my exam today. It's very challenging when you don't know the case and you are supposed to be live here and telling you. It's all the experience. I may be wrong at the end of it, but the approach is important. And all this I have learned from Dr. Amdekar sir. Like I remember my first case presentation to him, and everything I used to present to him, he used to convince me that it is tuberculosis. And his explanations were so apt that even a rheumatic heart disease was converted into a TB patient. And he used to, that knack of explaining, and that is what is required. And I've been an examiner for many years, and I want to tell all the postgraduates that you don't pass by making a diagnosis. You pass because all four of us are observing you. How have you handled the mother? How have you handled the child? How do you interact with them? How gentle you are with a sick child, and how do you get to a diagnosis? So that diagnosis, the supervisors have already told them. They know the case also. So it's not just great thing that they make a diagnosis. So I think let's start with it. And I once again thank everybody for giving me this opportunity to interact with you all. Thank you.
Thank you so much, ma'am. Now I will ask Shilpa to introduce the moderators and the team.
Good evening, respected seniors. So as the format of the session goes, we will be having 2 case presentations. I would request the participating team panelists to kindly unmute themselves and have an open discussion for the benefit of all present. Request all the other members to please be on mute and do not post any answers on the chat box. In case there are any queries, we will have the discussion with our expert and questions can be taken after that. So our moderators for today who would be presenting the case challenge to our panelists are Dr. Izhar Javed sir. Sir has done his post-graduation from JJ Hospital and has been practicing for the last 15 years in BED. And Dr. Abhijit Joshi sir. Sir is practicing pediatrician and intensivist at Chiranjeevi Children's Hospital since the last 22 years and with a special interest in pediatric rheumatology. So our 2 panel teams are from Nashik and Sholapur. So joining with us from Nashik are Dr. Amol Murkute sir, Dr. Tarun Kanade sir, and Dr. Abhijit Sangli sir. And from Sholapur, we have with us Dr. Samir Khan sir, Dr. Anna Saheb Lokhande sir, and Dr. Dayanand Nakate sir. So let's start with our first case presentation. I will request Dr. Abhijit Joshi sir to share his presentation, and this he will be presenting to team Sholapur. So that is Dr. Samir Khan sir, Anna Sahab Lokhande sir, and Dayanand Nakate sir.
Yes, sir. Yes, ma'am.
Sir, Abhijit Joshi sir, please.
Yeah, I didn't get you because I didn't get you. So that was my case is first.
Yes, sir. Yes, sir. Yes, sir.
Yeah. At the outset, I would like to thank Mahesh Mohite sir in giving me an honor of presenting in front of you all, and thank Kinikar ma'am to be an expert because she will definitely have inputs in this case. So I thank you all and all the organizers of the program. Yeah. So I will. Shall I share my case?
Yes, sir.
Just a minute.
Excuse me, which team is to answer?
Solapur.
Okay.
So very good evening to Solapur team.
Good evening, sir.
Good evening, sir.
Yeah. Whenever you feel like interrupting me, you can interrupt me at any time of because there may be many fallacies in presenting the case because I am presenting after so long, and I have some pressure of presenting a case in front of all such dignitaries. So we'll start with this challenge. So all the best.
Thank you, sir.
So in my case is she is 12.5 years old female, and she landed in emergency. She presented to us in emergency room, and she had severe breathlessness, and she had cold extremities and with pain in abdomen that was overnight. Before that, she had history of prolonged and increased menstrual bleeding over last 8 to 10 days, and she also had low-grade fever of 5 to 6 days. Going back 1.5 months back, she had attained menarche 1.5 months back, and that time she had prolonged and increased menstrual bleeding that time also. With that, she developed general weakness, listlessness, body ache for 7 days. She also had rash over body. It was all over body, but she recovered with treatment at local place and she got discharged after 7 days. But despite that, she continued to have lethargy, weakness, facial puffiness, low-grade intermittent fever, body ache, leg pains on exertion. So this is all going on for last 1.5 months, and she has presented catastrophically overnight. So in the negative, would you like to ask something just before I go to the negative history?
It's a history of joint pain.
There is no history of joint pains.
Vomiting.
She didn't have vomiting this time also. Only she complained of pain in abdomen, and she was very breathless. And the parents complained of she's feeling cold while she was presented to emergency room.
So this 1.5 month menstrual history, this she has menarche has achieved for the first time, and this is second episode of menarche.
November she attained menarche. November, December, and January. January was the last time she had.
But this is her second cycle.
November was first, December was second, and Jan is second, and she is presented in Feb. Yeah.
Okay, but this so this is 1.5 months. So now 3 months back, and first cycle was having prolonged and increased menstrual bleeding, and now this is third menstrual cycle.
Yeah.
But the second cycle was all right. There was no prolonged bleeding or any treatment received in between.
They think that was normal. Like
anything she has received after this prolonged first menstrual cycle. Any medication she has received?
That I will come to it later on. But she was hospitalized for 7 days, and she recovered with treatment. That is for sure.
Sure. Okay.
And she required one blood transfusion also during that hospitalization.
Yes.
Sir, I want to know whether how the breathlessness has started. Which symptom was started initially? Pain in abdomen, and where pain was localized. Whether
she had generalized pain in abdomen, and she presented initially with breathlessness, and then she had cold extremities, as the mother told us.
This is acute presentation of breathlessness, or
gradual? No, that is acute one only.
And whether this pain in abdomen was there in the previous cycle, like what I meant to say is dysmenorrhea, what we the pain.
That was there, which is normal
previous cycle also.
Menses. Yeah, but it was not exaggerated pain like this.
Okay.
Vomiting.
She didn't have significant. She didn't have vomiting, but this is acute onset developed over 1 day only.
Okay.
And going to the history of present illness, and in the going to the past history, I asked him about any previous history of bleeding, like did she have any recurrent epistaxis, melena, hematemesis, or any bleeding from any wounds in the past. But there is nothing significant about that. I even inquired about any bleeding disorder in family in the form of same complaints like epistaxis, melena, hematemesis, because I didn't ask about the larger bleeds, but I just asked about all these mucosal bleeds. And she's born of non-consanguineous marriage. She's second of only 2 siblings. Elder sister is 15 years old. Birth history is normal. She was a full-term normal healthy baby. She had attained normal milestones at proper age. Her dietary history is also normal, and now she is studying in 7th standard.
Okay.
So this is what she has presented to us, and in the past history, she didn't have any other significant complaints.
Okay.
So I will just have this. So these are 2 presentations. Like first time she was hospitalized in November, and second hospitalization was last month, like Feb.
But so initially, this time also rash is present. Last time also rash was present.
Yes. Rash was present. That was generalized rash.
And whether this rash was preceded by fever or the menstrual bleeding started first.
No. It was not. It was not coming with fever, but it was there in the previous episode also, and this episode also. It was not precipitated by fever, but she had low-grade fever.
What I mean to say is whether this fever and rash has precipitated her menstrual bleeding, or whether this menstrual bleeding, along with that, she has developed a rash and fever later.
No. That menstrual bleeding was that was going long time for 8 to 10 days, and that time only she had this rash. Rash was present throughout the like menstrual bleeding.
No. So the menstrual bleeding started first, and then she developed fever and rash.
Yeah, initially fever was not significant in the first hospitalization.
Okay.
That was low-grade fever, but along with that, she had, along with menstrual bleeding, she had general weakness, listlessness,
That is going to be
body
because she has
ache.
lot excessive loss, blood loss,
Yes,
and all
yes,
that.
yes.
Hypertension, sugar.
Yeah, and
But in
fever was
addition,
there.
so
Yeah.
difference between first presentation and second presentation, that she has additional breathlessness and pain in abdomen in this
Yeah, and
presentation.
this time
But
she had a marked fever. This time she presented with fever and breathlessness, pain in abdomen, and coldness of the extremities.
okay, sir. Okay.
Shall I move on to next slide?
Yes, sir.
Then?
Please. Yes, sir.
Yeah.
Please go ahead.
So this was a presentation in the emergency room where her general condition was very guarded, with vital signs of temperature of 103 degrees, heart rate 160 per minute, respiratory rate was 70 per minute, blood pressure for her age 104 by 60 millimeter of Hg. She had signs of moderate dehydration, and the capillary refill time was prolonged, more than 4 seconds. This rash which is described is over face, trunk, and extremities, which was diffuse erythematous. And she also had petechiae over lower limbs. She was in severe respiratory distress. The pallor was very marked. She also had subconjunctival hemorrhages, and there was a mild tinge I could see.
Okay.
Then, in emergency room, when she had was put a probe of saturation, she just had a 40% saturation in room air. With application of oxygen also, it didn't improve. So we applied high flow nasal cannula oxygen. With that also, it rose to 60%. Then she was to be put on NIV, and with NIV, she did well. Her respiratory system had shown marked decreased air entry on both sides, and she had bilateral basal crepitations. The abdominal examination showed the liver was 6 centimeter. That was tender. Spleen was also 2 to 3 centimeter. There was mild free fluid in the abdomen. On cardiovascular system examination, she had marked tachycardia with gallop, but I could not appreciate the murmur because of tachycardia. She looked a very anxious looking lethargic child. That is what she presented to us. And weight wise, her 52 kg weight lied between 75th to 90th percentile, and height also 152 centimeter, which lied between 50 to 75th percentile. This is what her presentation was in the emergency room.
Yes. So basically, a female child, 12 years old, with acute presentation with anemia, in almost going for a shock-like presentation. Hepatosplenomegaly with petechiae, with some amount of icterus, which is pointing towards maybe some hemolytic component, some maybe bleeding, all together going together. Especially a female child, almost 12 years old. So let's see. Any other positive finding? Blood investigations?
Yeah. Any drug, history of drugs?
There is no history of drugs. She didn't require any medications in the past. She was absolutely normal till she presented in November. She landed into menarche, and then all problems started.
Okay. Now, in between this, in February, when she got the second episode, whether she was on any medications or drugs she has received?
No, that was not a prolonged medication. She recovered within 7 to 8 days, and then all medications stopped. Maybe she was on some like hematinic or any other vitamin supplement.
Okay. Yes.
So this was the first time she was hospitalized at local place. She had 4 to 5 CBC reports where HB is 8.8, 8.5. Once it dropped to 6.8, probably I don't know exactly, she probably received transfusion that day, because 2 CBCs are done on the same day. And with that, next hemoglobin is 8.6, and again it is 8.7. The WBC count throughout is 6,600, 8,800, 5,300, and so on. Platelet count was 78,000, 1,19,000, 51,000, 1,09,000, and last one done in that was 1,53,000. Peripheral smear showed giant platelets, and this was over 7 to 8 days, and she got better and got discharged.
Can we have the indices of this?
Dr. Doshi.
Can we have indices
Yes,
of this?
please, Dr. Mohit here.
Yes, sir.
Pardon me for the interruption.
Yes.
Do somebody want to make a clinical summary and some primary impression at this point of time before going to investigation?
Yes, sir.
Yes, sir.
And maybe we can take our expert opinion also.
Yes, sir.
Because those things is about clinical. Yeah. Some differential diagnosis at that point.
She is a 12-year female child who has presented for the first time. She had history of prolonged menarche and then prolonged bleeding, and now she has presented in an acute shock-like condition with severe pain in abdomen and breathlessness. So probably this can be a thromboembolic phenomenon which has led to the pulmonary edema-like picture, because details are not with us, and because her room air SpO2 was 40% and blood pressure was, she was hypotensive. The two components are one is severe blood loss, and second is respiratory distress, and along with that she has got pain in abdomen. So this is acute exacerbation which is causing most likely this can be a clinical presentation. Samir, you want to add?
I think this is the female child. She is present with excessive bleeding, which is prolonged over a period of 6-7 days. So she has lost a lot of blood to cause severe anemia and gone to failure. But clinically also she has two-line drop, anemia as well as petechiae with conjunctival bleed, and some amount of icteric component, especially a female child, 12 years, thinking of an autoimmune disorder, whether she's going hand in hand, especially, but there is no joint, but she's still got a rash, which was there in the initial phase and now also, and a fever which is 103, but anxious looking, not toxic child. So immune disorders would be more on my chart.
So the hepatosplenomegaly part you would like to attribute to?
Splenomegaly is known for autoimmune hemolysis. Liver is known because of severe anemia, and hepatosplenomegaly is known in immune disorders. Some cases you can get with anemia and petechiae together. And thrombocytopenia, if it is severe enough, whether it is causing bleed, but that is again because 75,000, 80,000 is quite good amount of platelets to bleed.
That time she just had this rash. That time she didn't bleed. Only bleeding was in the form of hypermenorrhagia. Polymenorrhagia. Sorry.
ETP can be entertained as one of the differential diagnoses.
Could be one of them.
And can ITP, you said ITP, right?
TTP, thrombotic thrombocytopenic purpura.
Thrombotic thrombocytopenic purpura.
Because she has got rash, she has got petechial hemorrhages, then this thing.
Yeah.
Can you just go back to the case presentation, the first slide, please?
Yes, ma'am.
Dr. Arti,
yes.
I understand, but please don't give any clues. Once they finish, you are going to make a whole summary of the case. You are going to give impression at the end. You just note down their approach. We'll comment on the approach at the end.
Yeah,
Okay,
I just wanted to check one thing over
Yes.
here.
Yeah.
Yes, ma'am.
All right, go ahead.
Yes, ma'am. Yeah.
Sorry to interrupt.
No.
So this is what the previous hospitalization report. So she got better with the treatment and discharge. Then she was.
Excuse me, sir. As per this thing, indices you are not mentioned here.
Yeah, see, I couldn't get everything because that was done at periphery. I tried, but I could not get the peripheral smear and RBC indices in this case.
And HB dropped and ITP is only one line drop. Non-fracture. Less severe bleed.
Can it be bleeding disorder?
So
yes, go ahead, sir. We'll go ahead.
Yeah, next, So this is when she got admitted at Aurangabad. These are all hemogram reports. On 5th, she had hemoglobin of 5.4. On 6th, 5.1, 7.5, 8.5, 10.9. During this hospitalization, she was just given blood transfusion, platelet transfusion, plasma because she required stabilization. And she required NIV support for
hemolytic
with that she recovered, and she was given multiple PC pack red cells, then platelet and FFP transfusions. Her platelet count, as you can see, serially 10,000, 5,000, 5,000, then 7,000, 5,000. That was throughout. Her CRP, which was done on the day or next day of admission, was 33.52. There were not really, that was actually not with me, but there were not really serial CRPs done. Just ESR was done once only. Ferritin was done once, that was 79.8. Fibrinogen was 314. Her other reports showed serum Bili of 5.2 with direct component of 2. Serum alkaline phosphatase 51, HGPT 51, total protein 6.5 with albumin of 3, uric acid 6, creat 0.74, urea 29.5, PT 16, APTT 32. Her COVID IgG was done, that was negative. LDH is 330, retic count was 17%.
Hello, Oli.
Hello.
Sonali, please mute yourself.
Her corrected retic count for the anemia was 8.6. On peripheral smear, she had anisopoikilo microcytosis. And ultrasound bedside, which was done, showed hepatosplenomegaly with left pleural effusion, underlying collapse, lung parenchyma. She had mild ascites with cystitis.
Yes, sir.
Go ahead, sir.
Yeah, and one, any more investigations? I have not.
Here it looks like a hemolytic component going on. So drop in hemoglobin, drop in platelets, with bilirubin coming up, LDH on the higher side, retic count on the higher side. There's some hemolytic components, spleen, liver, and icterus.
Yeah, and any other investigation which I forgot to mention here, but you would like to ask?
X-ray chest.
X-ray chest is there, but before that,
ANA, DSDNA.
That is, we didn't think of doing it before. So anything other before hemolysis starts? Any other investigation before making hemolysis diagnosed before doing all these investigations? Or would you like to ask anything?
Peripheral smear.
A peripheral smear is showing a lot of the changes like anisopoikilo microcytosis, no abnormal cells.
What about the platelet aggregation?
DCT for this child.
What about the platelet
that's
aggregation?
what I was asking. Direct Kuhn's test was strongly positive. Yeah, DCT was strongly positive.
Autoimmune hemolytic anemia, female child, collagen vascular disorder.
Collagen vascular disorder, definitely.
So now you have both like immune, like it is thrombocytopenia with autoimmune hemolytic anemia.
Yes, sir.
Any other test, like you want to go ahead with the X-ray and yeah.
Yes, sir.
So these are the serial X-rays. The first X-ray which was on admission and the last X-ray is before discharge. So these are the changes over these days.
Resolution looks better. Yes, sir.
Okay.
So would you like to now summarize it and just want to go ahead with investigations, or you want to summarize it again?
I think still I'll go with the same which I had started with. 12-year-old female child, hepatosplenomegaly with evidence of thrombocytopenia with bleeding, liver spleen present, and lab investigations evidence of hemolytic anemia with multi-system involvement, pleural effusion, pain in abdomen, 3-4 systems involved, more like a autoimmune disorders, especially female child like to think of collagen vascular disorders. Investigate further on that line.
Yes. So what investigations would you suggest?
Yes, sir. I think it is around 21 something. One
No,
document.
17. It is just 17.
Just 17.
Only
Like,
one was one.
Yeah, and CRP is also not very much. The CRP is 33.52.
33.
That was, I think, was not with me. Actually, must have repeated, but I have only one report.
Okay.
Would you like to have a comment on ferritin, fibrinogen, and
ferritin is low.
Even if a female child of autoimmune condition, whether she's going for a complication like a mass-like presentation, so if she's going for those complications, ferritin would still be on the higher side, and fibrinogen would be on the lower side, which is not seen in this
case.
Yeah. Initially, we thought of that because she had run a high-grade fever, and along with that, she presented with all these cell lines down. So we thought of MS. Yeah. So we got ferritin done, fibrinogen also done, triglycerides also were done. Where those also were normal, but that DCT came strongly positive. So I will just show the clinical picture now. So there is one complication also we can make out in the clinical picture.
It's got she's got a discoloration of the peripheral digits, which is typical of autoimmune disorders, which is gangrenous changes in the finger digits.
So for that microemboli changes, would you like to suggest any investigations, any associated condition for that, or would you just label it as
anti-nuclear antibody and dsDNA?
Any dsDNA would be definitely on my list. PTK with INR.
Yeah.
So this is her
malar rash. This is classical of SLE. She has face is showing classical SLE. Butterfly rash over the face and nose.
Had I shown this slide before, so you would have directly said this is SLE. So I showed it in the last.
Okay.
So these are her reports. The ANA by immunofluorescence is 1 in 3,200, which is significantly high. Serum C3 19.8, C4 2. Anti-dsDNA is strongly positive. SM antibody IgG is strongly positive. Lupus anticoagulant is absent, and she had a VDRL test which was also positive, which is indirect evidence of this. This just I was asking whether you would ask any other tests, like after proving it this is because of SLE. So any other investigations would you like to do for this discoloration of the digits?
Like the Doppler flow.
Yeah, that, and any blood investigation. Would you think of any condition? Yeah, lupus anticoagulant is absent. So any other specific tests? So this is like the VDRL has is positive. That means it is an indirect evidence of. And as a part of the workup, we had to get urine routine done, which is showing 2+ albuminuria. Urine protein create ratio is 1.57, and her last hemogram before her discharge was planned, that was showing all cell counts normal.
ELISA
for HIV is negative. So we just asked for anti-cardiolipin antibody and anti-phospholipid antibody. And lupus anticoagulant is absent. So we thought of Raynaud's phenomena because SLE is sometimes associated with Apla syndrome. So we thought of that and we're getting it done. We got the kidney biopsy done. We are yet to get the report. So we are treating her on the lines of management of SLE patient.
Yes.
Eyes were checked for iritis, iridocyclitis.
That actually we got it done later on. Everything was done later on. So she's yet to go through all these tests, and she's following up with another hospital. So we'll get the reports as early as possible.
Dr. Joshi, you have finished the presentation. You can please stop sharing the presentation. You have finished it.
Yes, sir. Yes, that presentation is over.
Then we'll have the experts comment. But excellent approach by the Solapur team. Congratulations.
Thank you. Thank you, sir. Thank you. Thank you.
sir.
Yeah. Over to Dr. Arti Kedikar for her expert comments.
Very good case, Dr. Joshi sir. And also both, I want to congratulate both the team members from Sholapur. Very focused questions were asked. To
Thank
me,
you, madam.
if you go back to the history, this diagnosis should have come from the history.
Yes.
Yes.
Almost all
Adolescence female
investigations.
suddenly presenting in shock.
Very good. So you
And
have
with
to start with that.
precipitation at the age of menstrual this thing. So this is commonly seen in SLE.
Anything else?
Along with that, she had a rash also and generalized weakness. Facial weakness.
Yeah, so what does it tell you? Is it one system involved or there are multiple?
Multi-system involvement.
Look at what Dr. Joshi sir has put up in his presentation. If I like to go through the
she had severe breathlessness and cold extremities.
Yes.
And pain in abdomen. So this was a main complaint what she got presented for.
So why is there pain in the abdomen?
Yeah, pain in abdomen is there.
Why?
So why is it?
It is because of the what we call it as
Ischemia is very common.
Ischemia or slightly what we
in this particular case.
See, every symptom which was presented, you have to find an answer for it. Ask the question why. And if you have that answer, start writing it down. So I would like to go back to the slides if it is possible, because I can
I'll just share, ma'am.
take you through the.
Yes, ma'am. Yeah.
You have to explain every symptom which has come over there, no?
This is we can make out from this symptom.
No, can we go back to the previous one?
First slide.
First slide. See, over here, this child has come in emergency. So you have to have an emergency diagnosis. There is a resident attending to this or you are attending. So there are certain emergency diagnoses which you have to make, emergency treatment initiated, and then you find out the cause why this child developed it. So the age, if you look at all your history, how has she been up to her onset of menstruation? As far as growth, development, she is a
normal growth and development.
Normal, healthy child.
Yeah.
Everything here is associated with the menstrual cycle. The moment it started, everything has gone wrong. And she's recovering from it. She recovers from the first attack, then the same thing happens. So it is something which is recurring, right? The underlying on the background. But when she came to the emergency, severe breathlessness, cold extremities with pain in abdomen, which is overnight. So as a pediatrician on emergency duty, what is the diagnosis here?
Yeah.
So respiratory involvement, maybe with cardiac, cold extremities tell you what? And pain in abdomen. For some time, forget that you have diagnosed SLE in this patient. Forget it.
Yeah.
When you saw this child, what would be the normal thing? Is the child in shock?
Definitely. Child is.
So that is the cause of pain in abdomen. That is the cause of cold extremity.
So our working diagnosis was a shock with respiratory distress that we commented.
So
the
Yeah.
cause for shock is
yes.
It can be severe blood loss, or this is a just what we get in typical collagen vascular diseases. We get in patient usually get in presentation as a shock.
Yeah, so you already got a history that for last 10 days she's got heavy menses which is going on. So you have a cause for the blood loss. Why is there low-grade fever?
Again, they are prone for infections. And
inflammation is also inflammation.
So you think this low-grade fever is because of inflammation. In the history, if she has just started having menarche, what else would you like to ask, which is not there in this history? That pain in abdomen, shock, severe breathlessness.
Usually they may have some flushing attacks or something, what we call the change in fluctuation blood pressures.
Yeah. Always ask how she was taking care of the bleeding. What sanitary napkins she was using. Was she using something like tampons?
Yeah.
Okay, because there is first episode and it had rash, etc. All that coming up, then it subsided. Then she comes to you second time, she uses the same thing, and she comes to you in a toxic shock-like state, isn't it?
Yes.
Is it possible? I'm talking
it is
about
possible.
the emergency thing. So the history of what was used, because prolonged bleeding, whether they were using homemade cloth and it was not washed properly. So all these things has to be looked into. Okay, so history always menstrual related, ask for it. Now this rash which came up, it was all on the lower limbs to begin with, then it increased. So that rash has been described on examination afterwards, okay? So even an allergic rash to the sanitary napkins, etc., all those could come. So always keep that in mind, and it is recurring. So it's a recurring problem, first episode, second episode. Now lethargy, weakness, and facial puffiness, body ache. What does all this tell you in this patient?
Anemia.
Anemia, chronic
One is anemia. What else like this facial puffiness, and then subsequently there is a mention of eyelids being
conjunctival congestion. Yeah.
Congestion. So if on this first slide, how many organs in the body are involved? If you can just enumerate.
Some renal involvement.
One is the hematological.
Hematological. Another is respiratory.
Very
Third
good.
one is pain in abdomen. That is abdominal system involved.
Yes.
Yeah.
And
Renal.
Renal plus minus. Okay.
Yeah.
Okay.
All right. And overall anemia related weakness, which is there. Okay. So this slide tells you that it is a acute on a recurring problem, which is causing multiple systems involved, and the primary being the hematological, because it's causing a lot of problems along with the menstrual bleeds. And of course, it also has a rash, which is coming and going away with treatment, isn't it?
Yes.
So then when you go to the next slide, here it is, everything is normal.
Yes.
Okay, no family history, nothing. So it is nothing that has been present in the family or in this child since birth.
Yes, ma'am.
So can it be some acquired problem?
Yes.
Possible or no?
Yes, ma'am.
Yeah, so it is an acquired problem.
Problem.
Which is recurring. So you go on adding one word over there. Next, please. Next slide.
Yes. This is the
This is
graphical.
called the timeline. Okay,
Yes.
all
Yes.
chronic cases, acute on chronic, always do a timeline, which Dr. Joshi sir has done it very well. And you look at it, they are the same symptoms occurring.
Yes, ma'am.
Isn't it? So can we use the word recurring? Waxing, waning.
Yes. Yes.
With or without treatment. So that is what the history should come out with. Okay, facial
Yes.
puffiness, low grade. Keep in mind whether the renal system is involved along with the hematological and whether all this is related to anemia. Next slide, please.
Yes.
Right. So on your history, you will have a healthy child who develops a problem at 12 years of age, which is recurring with the same symptoms associated with menstruation, with evidence of anemia, breathlessness, which is coming with and a rash and multiple system involvement. Okay. If that is what you get an idea from here, that the skin is involved, blood investigations like blood hematology involved, and then a respiratory problem plus minus cardiac. We don't know yet. Okay, renal plus minus.
Yeah.
Okay, right. So then the next part comes as focused examination. So in the history, I would have gone in detail about how she handled her first menstrual cycle and the details to rule out a toxic condition, toxic shock like condition, which is happening with the use of the same pads or material used. So from examination, is the BP normal for her age?
No.
12 and a half years, 104, 60.
It is corresponding to 50th percentile. Yeah.
10%, about 10%.
Yeah. So there is tachypnea, tachycardia with around 50th percentile, and the CRT is prolonged. So she's come to an emergency room with all this. Do they favor shock?
Yes.
Yes. Compensated or not compensated?
Compensated.
Compensated.
Because blood pressure is around 100.
Compensated, isn't it? And the rash is now not only on the trunks, but on the face also. And Dr. Joshi very nicely never told us it is a butterfly rash. Okay. We kept it under that. Okay, but there is a mention of petechial rash.
Yeah.
So there is a petechial means your platelets are involved. It is a diffuse rash which is there. Some more details about this rash, whether it was itching, was it non-itching, was it a painful thing, was there bleeding from anywhere else?
Okay,
that is very, very important. It is only and only menstrual.
Yes.
Okay, so there is no bleeding from anywhere, gums, etc., nothing. And then there is, of course, pallor, subconjunctival hemorrhage, and icterus. So the icterus tells you what?
Hemolytic components.
Hemolysis.
Indirect hyperbole.
Yeah, or keep in mind liver involved. Okay, we have yet to go ahead.
Yeah.
All right, so next slide, please.
Yes.
Now the initial part, SpO2 40%, what does all that tell you? Requiring oxygen 60% and all. That she's
brain involvement also, hypoxia or respiratory involvement.
Yeah.
Demands are more and she's not able to get the...
yes, but at the same time, your saturation is
falling. It's 40%. Yeah.
So what does that tell you?
Tissue hypoxia.
There is
on saturation. You cannot judge on SpO2, but we if you have got ABG also, then would have been able to comment on the ABG, tissue hypoxia.
There's amount of ventilator mismatch is there.
VQ mismatch is there.
So is there some
because of fluid in the lungs?
Sorry to interrupt here. We have only 5 minutes for this case. We have one more case following this.
Yes.
You can't finish more, Mahesh, in 5 minutes.
No. I wonder your PG clinic will go on this case itself for another 1 hour, but there is another one more case to be presented.
This case requires 2 hours.
Yes.
Okay, so it also you have to keep in mind that there might be some lung compromise.
Acute lung injury.
Otherwise, this would have got corrected on its own. Okay. Then you are having the liver and spleen. You have said liver is tender. So is it related to the anemia and the congestion? And of course, the spleen doesn't come like that. So it tells you that something is going on, hemolysis. Okay, next one, please. and then you come to all your investigations. So based on the history, a recurring problem, same thing what we have dealt with on the history, and plus you have additional problem that there is a lung involvement, also ascites, etc., all those which are there. So it is a polysero involvement as well. Yeah, so you are getting
one important investigation, that is ESR is misleading in this case. Usually what we come across in SLEs is more than,
ESRs are very common.
yeah. So there is this is not this is little controversial.
Even for the degree of anemia, the ESR was normal.
Yeah. 17 of ESR we cannot think would have been. This is totally misleading, this thing.
Okay, there is a peripheral smear showing giant platelets. Can you give differential diagnosis for that?
Adhesive is there. That is Glanzmann's thrombocytopenia. You can get giant platelets, or sometimes we can get it because here 3 lines are affected. One is hemoglobin is affected, platelets is affected. So if the single line would have been affected, we would have thought of platelet disorder in the form of viscous syndrome or Glanzmann's thrombocytopenia.
In that, some platelet count would be normal for them.
Sometimes
giant platelet only tells about that only tells
only
about
the hemolysis, the large size platelets are there.
Increased megakaryocyte turnover. It only indicates increased megakaryocyte turnover. In response to the acute hemolysis
breakdown of platelets. Okay.
Yeah.
So just keep in mind that there will be a differential diagnosis of platelet-related problem also in this patient. If it is not low platelets and all the count was normal or higher, then it's a platelet function disorder. Okay. And then you go on examining, you found those, that was not shown to us now, but later, but there are evidence of thrombosis. The fingers had those thrombotic features which were there. So if you examine properly, you would have known that it is not only platelet petechial rashes, low platelets, but also thrombosis. So one
of the differential that's why I kept was PTP. Because basically the rash distribution, and if it have been presented in the initial phase, the first diagnosis would have been SLE. But as this patient has went into shock, and pulmonary edema can be presentation because child is presented with breathlessness and respiratory distress and with shock. So TTP can present like this.
Yeah, but TTP.
So that was one of the differential diagnosis kept in initially phase.
Yeah. But DCT coming strongly positive with acute, so it was ruled out.
Ruled out. Yes.
So that is how you go next, please, quickly, because no time now.
Yes.
So now when you look at these things, there is a hemolysis which is going on. So it is not just related to the periods which are there and it is coming again and again with platelet dysfunctions and all, but chronic hemolysis which is going on. And there is a lung involvement which has occurred over here with infection in the cystitis has to be explained. Again, go in details about the menstrual hygiene. Okay? Because if you don't counsel her properly over here, she may one day really come into a toxic shock-like syndrome. Okay, so that is very important here. And it's not just the platelets and HB. Later on, you will see even the WBC counts have gone down. So all 3 series are getting involved. Next, please.
Yes.
And this X-ray, you will see these, we used to see it for ARDS also. Yeah, same type of pictures which were going on. So intercurrent infections, if she has come during COVID time, which has rightly you all have done it and shown that it is not infection, it's more of a polyserositis-like involvement and child getting better. The lung parenchyma appears to be normal. Next, please.
Yes.
And now this is what he has very rightly not shown it to you to make a diagnosis. So all this could have been come earlier also with the same approach with multiple involvement and occurring at around 12 years of age. By commonality, you can go for it. But always keep differential. Why is it not a hematological disorder? Is it related to some factor deficiencies recurrent happening like this, rash with this, which is the only condition. Bleeding with rashes, otherwise she gets better and she's all right. They can have any factor.
Porphyria can present with this shock, rash, and sudden shock and
that abdominal pain.
That is porphyria can be entered in one of the diagnoses.
Yeah. So porphyrias can happen with acute excruciating abdominal pain. So try to describe that pain in detail if you want to keep porphyria as a thing. Any coagulation problems, deficiencies, defects which are there, coagulation. Any factor deficiencies or something like that.
Being a female child, we ruled out hemophilia and hemophilia B. Those were ruled out because she's
Von Willebrand.
Willebrand. Yes.
Okay, so whenever we conduct exam, we don't ask them anything about SLE. We ask them about everything else except SLE.
Yes.
Okay.
Yes.
All right. So well done. I think, Mahesh, I will stop here before you again reprimand me.
Thank you, madam. Thank you.
Thank you, ma'am. Thank you, madam.
Thank you, ma'am. Thank you very much. Yes.
Thank you, ma'am. So that was a very interesting case presentation and very well discussed. Thank you, Dr. Kinikar, ma'am, so much for that detailed dissection of the case, right from each symptom. But we have one more case to go, so let's start our next case.
Yes.
Sir, I request Dr. Izhar sir to please share his presentation and Team Nashik to be ready. So Team Nashik has Dr. Amol Murkute sir, Dr. Tarun Kanade sir, and Dr. Abhijit Sangle sir. Please unmute yourself.
Yes.
Good evening, everybody. As we have an expert from JJ, a coordinator from JJ, myself from JJ, I am presenting to one of my dear from JJ. So let us carry on the legacy of Dr. Y.K. Ambedkar. We'll start the discussion. We are interested in approach to the case rather than diagnosing it.
Yes, sir.
Right. Yeah, we have a 6-year-old female child, first by order of birth, born of a non-consanguineous marriage, presented with history of vomiting, abdominal pain of 1-day duration. Fever is high grade, continuous, responding partially to antipyretics. Child used to be lethargic in between fever spike. Child had a non-projectile, non-bilious episode of vomiting associated with fever. Abdominal pain is dull aching, localized to upper abdomen. There is a decreased oral intake and jaundice noticed by the parents on the same day. Child did pass a high colored urine twice since morning, and child passed a pale colored semiform stool once since morning. There's no joint pain, rashes, bleeding on direct pushing. So with this short history, I'll be asking my team to give their inputs. What are your thought process on that?
Yes, sir. Amol?
Sir, if we take the fever first, fever which is high on onset and of 1-day duration, my thoughts are on the line of viral or bacterial, which is at the site of localized to one site.
So we are not interested in etiology. Our
Okay.
first thing will be an anatomy, then we'll
Yes,
go
sir.
for pathology, and then we'll be going on etiology. So just
Anatomy is probably hepatic etiology, sir.
So good. So we have a acute liver injury.
And here with fever, the child is lethargic in between spikes, and partial response to antipyretic means it's a serious infection or serious problem, not infection.
Very good.
And
so this is a
yes, sir. Yes, sir.
Yes. So acute. It's a very acute presentation. 1-day history. Very high grade fever. Child not well between fever spikes. So that definitely whatever the issue is, it's a severe problem. Decreased intake and jaundice points towards liver pathology. There is dull aching pain in the upper abdomen, again points towards the liver or gastritis. Again, clay colored stool is probably pointing towards obstructive pathology. So everything points towards acute fulminant presentation with involvement of the liver and hepatobiliary system, probably infective in origin. or obstructive. So we'll have to go for that on examination. And
so you just mentioned infective in your origin.
Sir, can I talk, sir? One more thing.
So I'll finish with Tarun and then I'll talk to you. Once you told me that it's an infection, Tarun. So what infection are you suspecting with 1 day history of jaundice and a sick child?
So usually what hepatotropic viruses we talk about, hepatitis A, B, A and E, they present with acute fulminant, can present with acute fulminant hepatitis.
Do you think this is a garden variety of hepatitis infection?
No, sir. This is a fulminant hepatitis, sir.
So
1 day history.
So I think there has to be a dilemma whether it is just a hepatitis, because this is not a prodrome which is preceding the onset of illness. Prodrome has to be there.
Clay colored stools also. So again, it goes in favor of a biliary involvement also. So this is not purely hepatitis. There is something else also going on.
Okay, so you think that's it? Can it be a drug-induced stuff? We don't have a history, short history. So anything else?
One more thing.
Paracetamol can cause, but we are not sure.
We don't have the history. Let Amol talk.
Yes, sir.
Yes.
The parents have noticed jaundice on the day of vomiting. That does not mean the jaundice. That does not mean the jaundice has started on the same day.
Yeah, they are educated parents. Both parents are doctors and they can notice it.
Okay. And another thing is, I would like to ask, how well was the child? Like, is there any?
So I'll come on this one past history subsequently. My intention was on chief complaint. What can I expect from you? So it's an acute liver injury from all of you. Probably it's a liver disease or a biliary disease which is combined, and more likely to be a fulminant or severe type of injury. So
or there is some chronic problem and there is some acute on chronic
issue.
So
we don't know. Probably we'll go for the history and subsequently we'll add on that.
Yes, sir.
Yes, sir.
Yeah. So there is a history of similar illness at 3 years and 4.5 years requiring hospitalization. Fever used to last for 7 to 10 days with progressive increase in jaundice. Gradually, child used to improve with treatment. Child never had seizures or any bleeding at both the admissions. Jaundice used to decrease over 3 to 4 weeks. No blood transfusion required in past. Child used to be normal physically in between the episodes. So we have a birth history, spontaneous vertex delivery, 2.8 kg, no perinatal insult. Family history is the only child born out of non-consanguineous marriage. Development is normal for her age, and vaccination for hepatitis B and A is there. Look at this growth chart. I want everybody to notice that. So we have a 6-year-old child who's having weight of 20 kg, which is 50th percentile, height of 118 centimeter, which is 75th percentile. So it's a well-grown child, at least at this point of time.
Yes.
So on examination, I have a child who's dehydrated, there's no pallor, there is a significant scleral icterus, no lymph nodes, sensorium alert looking around. For abdomen, liver is 3 centimeter below costal margin, with span of 8 centimeter, tender, no spleen palpable, no free fluid. Rest of the systemic examination is normal. So now analyze with the history, past history, anthropometry, and examination finding what we have. What are we dealing with?
So there is a recurrent hepatitis, okay, which is resolving completely. The child is well grown, so it doesn't appear to be a chronic. There's no chronic hepatic failure per se. It's just a recurrent hepatitis which is coming up. Is it precipitated by some events, or is it precipitated by some infection, or is it precipitated by some drug?
We don't have history, but by and large, you can consider you got some infection and it is getting precipitated. Okay. You have any other thought process on that?
So because autoimmune hepatitis can come recurrently, okay.
So I am not interested in diagnosing. I just want an acute recurrent hepatitis, your acute recurrent liver disease you are telling me.
Yes, yes, sir.
Acute recurrent. Okay, so you think you have a disease which has come up at 3 years and then 4.5 years and 6 years. They are all the same. They are not different. Presentation may be same.
Presentation appears to be the same, sir.
So do you expect if somebody has got a illness at 3 years and the child is symptomatically well in between episodes and he has not progressed till 6 years? So if you just told me there is something like autoimmune and then the child is absolutely fine in between and having a good growth.
No, this is just one possibility I was thinking about.
So just tell me what is the other possibility? Why not it is a chronic liver disease which is compensated?
So chronic liver disease will have some growth failures. The child is well-grown child, and the child is very well between the episodes.
That's excellent. When you call it decompensated?
So when there is decompensated, will be there will be free fluid in the abdomen. So there are signs of hepatic cell failure. CNS will be involved. Child is alert looking. There is no free fluid in the abdomen. There is a tender hepatomegaly. Usually, if the liver is failing, the liver size will shrink, and there will be no tenderness. So there is a chronic fibrosis if it is there.
Okay, so decompensation when somebody bleeds or go in encephalopathy. Excellent. What do you want to say, Amol?
Yes, sir. This is not decompensated disease. You have mentioned reticular endothelial, but there is no pallor and there is no transfusion history. Plus, there is no.
So you need to have a pallor for having a reticular endothelial disease?
No, not for hemolytic anemia, I am telling, sir.
So what has told us to which hemolytic anemia will manifest with recurrent liver disease or recurrent liver cell involvement?
So spherocytosis can come with that.
You think that's hyperhemolysis causing direct jaundice?
But there should be spleen also.
Okay, that's fine. What is more common? You know, any hemolytic disease which cause vascular involvement and obstruction and necrosis of hepatic cells because of vascular involvement. Very common.
Malaria.
Somebody stays in Nagpur area. Vasculopathy.
Sickle.
So that explains at least you have a mixed jaundice or rather than a just hyperhemolysis. Any storage disorder which can come up like recurrent acute liver cell involvement.
Galactosemia.
But that used to have manifested so early.
Yes.
We had manifestation at 3 years of age. We should have progressed, we should have growth affection, failure to thrive and rest of the manifestations.
Correct.
Anything else?
Can it be Wilson? Yes,
okay, Wilson's probably you told me Wilson presenting at 3 years something very unusual. Even if it might have presented with liver cell involvement at 3 years, might have progressed to compensated or compensated liver disease. Our growth parameter doesn't tell.
Yeah.
CNS weight that come at adolescence, probably
6-7
years down the line. Okay, so we had cut short at probably it's not a reticular endothelial disease. Biliary disease, do you think there's some abnormal intrahepatic bile duct abnormality which is getting infected again and again?
Clay colored stools are there, sir. So there's a possibility of a biliary disease.
So biliary diseases are isolated or they are hepatobiliary disease?
They are usually hepatobiliary, sir. I mean, they're isolated. Only biliary will be like a calculus causing obstruction leading to cholecystitis, but that will be a very acute fulminant presentation again.
So that presentation has come up at the age of 3 years, and now the child is 6-year-old. So you do think that you have a recurrent calculus obstructing biliary tract? That will be for any congenital liver disease which has come up at 3 years of age with a cholangitis episode and then that episode subsided.
Colodocal cyst.
Colodocal cyst.
Okay, that is not infected. There is a broad spectrum for this one malformations associated with biliary tract. So Carolus syndrome, you can have a liver involvement which is asymptomatic and then probably you can have a cholangitis recurrent which is coming up.
So can it be a hepatocyte function problem? Although the child is sick, can it be a conversion problem? But although
yeah, I do agree if you consider an intermittent metabolic disorder, like what you want to say, a mitochondrial disease or something like a beta oxidation defect, which has been asymptomatic initially and now decompensated with probably an infection, you can get a recurrent liver function problem. But for that, again, I think any liver function problem which is acute in nature, we are not more bothered about jaundice. We are more bothered about race-like phenomena like encephalopathy or bleeds rather than a child who is having jaundice and then stabilizing over a period of 3 to 4 days. And probably you can have also growth involvement or other system involvement rather than a localized liver disease. They are very sick, very difficult to resuscitate and then Probably they have associated growth fever, which may not be there depending on the defect in enzyme level. Anyway, last option we have hepatic venous occlusive disease. Can anybody tell if there is a possibility of hepatic venous occlusive? Which one? Biliary. Okay, okay. There is a dictum when you have a jaundice, then a hepatic venous occlusive disease are the last thing you should talk of. So you have hepatomegaly.
There with Biliary.
Yeah, you can have hepatomegaly, you can have ascites, but never liver cell involvement. So liver cell is intact. So our all history goes around a liver cell disease, which is recurrent in nature. So Biliary not well taken because we have a jaundice in this child. Shall I proceed for investigation?
Yes, sir.
Yes, sir.
This patient had fever with jaundice on the first day.
Yeah.
So hepatitis A or hepatitis E is ruled out because in hepatitis A there is fever for 3 to 4 days. After disappearance of the fever, jaundice appears.
We already discussed that prodrome is absent in this child, but that is not a rule. So you can have absent prodrome in acute hepatitis, but you are correct. This child doesn't have prodrome, so it's unlikely to be an infective hepatitis.
We are getting some outside help.
Other tropical diseases like dengue, malaria, leptospira, or typhoid can present with jaundice with fever.
So actually, we have to think about this. You have a one-day history of fever. Even if I think of a dengue or a leptospira, which are more malaria, I can consider a complicated malaria with vascular obstruction causing hepatic involvement. That's a complicated malaria. That is well taken. But lepto, dengue, all are bimodal or biphasic illnesses. So usually their second phase has liver involvement rather than a first phase. And you will go for the investigations. So Tarun, this is basic investigation. CPC is 12 gram, WBC count is 6,600, platelet is 2 lakh, peripheral smear normocytic normochromic, LFT serum bilirubin is 18, direct is 14.5, indirect 3.5, SGO2 is 2200, SGPT is 1625, GGT is 120, serum albumin is 4.5, PT is 25 with INR of 1.95, PTT is 49. Renal parameters are normal for age. You have a negative serology for all viruses, leptospira and malarial antigen. So, Tarun, I just want your impression on LFT.
Yes, sir. So there is a rise in direct jaundice, sir.
Yeah.
There is involvement of SGOT and SGPT, both are raised. However, SGOT is more as compared to SGPT. The GGT is normal, albumin is normal, but the INR is prolonged. So there is a defect in the synthetic function. There is hepatocyte destruction also, and there is intrahepatic cholestasis. There is some cholestasis. There is a direct jaundice, though it looks intrahepatic because GGT appears to be normal. Other things are negative. So infective pathology is less likely, sir. It is mostly a hepatocyte function and which is delayed. It is acute onset because the albumin is normal. So chronic, it is not affected. It's an acute hepatocyte affection.
Excellent.
Plus, sir, SGOT is more than SGPT. So it is less, hepatocellular function is less affected than.
No. What it means? SGOT is raised more than SGPT. What it indicates?
There is extrahepatic.
Yes, SGOT more than SGPT is more of extrahepatic hypoperfusion kind of thing. SGPT will be rise more in hepatocellular dysfunction.
Okay, for poor pediatrician like me, if I have a raised SGOT compared to SGPT in a child with hepatitis or a jaundice, I'll consider probably it's a multisystemic disease. So SGPT is more restricted to cytosol of liver cell. SGOT, you have RBCs affected, skeletal muscles or cardiac bone involvement. So probably it's a multisystemic rather than a systemic. Or what you told, any ratio related to SGOT, SGPT, all those ratios are there in adult hepatology, but they are not very well refined in pediatric hepatology. So, do we want any specific investigation to be done in this child?
Alkaline phosphatase.
So, alkaline phosphatase, I did it's significantly raised. It's around 900 for a 6-year-old child.
Okay. So that means there is some obstruction.
Okay.
It looks like intrahepatic cholestasis because the direct bilirubin is there.
GGT at 6-year-old is 55, so it's also raised.
Raised.
So ultrasound for any intrahepatic.
So I'll do an ultrasound. So this is an ultrasound. There is mild hepatomegaly, normal liver ecotexture, no portal hypertension, no spleen, no free flow.
Okay.
So still you are on biliary tract, or the biliary tract is ruled out.
Can be still intrahepatic.
Extrahepatic biliary apparatus.
So you had ruled out extrahepatic biliary abnormality, or you can blame an ultrasound sonologist. He had not seen that. So probably you had seen.
Is the gallbladder seen in the USG?
Yeah, it's very well seen, sir.
Okay. So urine routine is showing positive bile salts, bile pigments?
Yes, sir, in large quantity.
Okay. So there is a direct jaundice, and it is causing only mild hepatomegaly.
So it's a mixed jaundice. Nobody told you it's direct jaundice. You have a direct and indirect, both bilirubin raised.
Yeah, but direct
It's
is
a
more
mixed
than indirect.
So it's a mixed jaundice.
Mixed jaundice.
Yes, sir. Okay.
Any other feature for Wilson, like eye examination?
So whether you will investigate this child for Wilson, this is my first question. She started at 3 years with liver cell disease.
Less likely, sir.
And not progressed. Growth parameters absolutely normal.
Less likely.
So still you want to investigate for Wilson's?
No, sir.
I will do, because I know that's the only thing which I can treat.
Serum ceruloplasmin we can do.
Okay, serum ceruloplasmin. Anything else you want to do?
We can do an eye examination. KF for KF ring.
We had seen KF ring. Unfortunately, it's absent.
24-hour urinary copper.
Okay, we did that. I'll tell you the report. Anything else you want to show?
It's recurrent.
Tarun, you made the diagnosis on history. You told acute recurrent. There is some thing which is acute recurrent. You just told me whether you want to investigate for that entirety.
Stones.
Acute recurrent, you told first thing.
Yes.
You told an etiological diagnosis first. You want to say that? You want to see, look for an autoimmune disease in this side?
We can definitely look out for autoimmune. Autoimmune hepatitis is known to come recurrently, and it has acute presentation. So we can look for anti-SM, anti-LKM antibodies.
Okay, that's excellent. So we have a specific investigation. You got a KF ring absent, serum ceruloplasmin 40, which is totally normal. 24 hours urine copper normal. AN is negative. You have got an immunoglobulin level which is 3,500. Up to 1,500 is supposed to be normal for a 6-year-old female child. You have LKM antibodies which are large positive. In one lab, 1:10 dilution, and one lab, 1:40 dilution. So what is your diagnosis now?
So it's autoimmune hepatitis, sir.
So first thing you had ruled out, it is not a infective hepatitis. That's the first thing you should do. So you had ruled out it's a seronegative, or probably non-infective hepatitis. So you got a large immunoglobulins and LKM antibody positive. So there is a possibility of autoimmune hepatitis.
Yes, sir.
So we stabilize the child with not so great treatment, just on IV fluid, and then probably a good diet. And then after 6 weeks of stabilization, we found that bilirubin of the child is 2.11, SGPT is 200, SGOT is 200, GGT is 66, and PT is 13 seconds. So parents are doctors, so it was difficult for them to convince further what treatment we should offer to them, because this is 3rd episode. So do you want to do any investigation? we'll wait for another episode. 1.5 साल में एक बार हो रहा है, वो भी 5-7 दिन में तो अच्छा हो जाएगा.
No, we don't wait for another episode. So we need to work him up.
Okay. So that is one thing. You have recurrent illness, we'll investigate. So what investigation is left out?
Mycoplasma, sir, because it can cause.
Okay, any specific investigation?
Biopsy.
Good, excellent. Excellent. So that is the most important investigation. You can suspect autoimmune hepatitis, but you have to document it. Unless you document, you are not going to treat it, because the treatment will be a lifelong, probably a long-term immunosuppressant. So we did a biopsy at KM Pune. So there is an evidence of characteristic mononuclear infiltrates invading the limiting plates called interface or piecemeal hepatitis. There was lobular ACT formation in hepatic cells. So our diagnosis of autoimmune hepatitis got confirmed. So the child was started by Vishwadesh only, oral prednisolone, and then subsequently oral azathioprine was added. That was gone for 6 months or so. The child is under follow-up of us for almost 1.5 years. No recurrence, no transaminitis, growth velocity is normal.
Great.
So this is just theoretical part. We have type 1 or type 2 AIs. This child fits in type 2 AIs, which is supposedly more severe category, had more chances of recurrences and relapses, and very difficult to control, may require a long-term immunosuppression with low dose steroids and azathioprine. I'll go back to our expert who's from JJ, and we need a blessings from her.
Thank you, sir. Thank you, sir. Excellent case.
Thank you.
You can stop screen sharing, please. Or madam, you want to look at the slide?
No, Dr. Azhar has presented it so well. And
Dr. Izhar, please stop sharing your slides. Dr. Izhar, please stop sharing your slides.
Stop sharing.
Yeah, go ahead, Dr. Atik.
Yeah. So first, let me congratulate the team as well as Dr. Azhar, because he has approached the case so well and so systematically that you don't need any hi-fi tests. They are all basic tests which we do during our training as well. Now that the other investigations are available, you can specifically make a diagnosis. But if you look at the case, are there some pointers where we could have thought about it right at the beginning? So which are the words that are important when you are asked to analyze the case only on the history, then on the examination, and then on the investigation? So what are the words that are important in the history which was presented?
Acute presentation, ma'am.
Yes.
Recurrent presentation.
Yes.
Growing well.
Yes.
Apparently in the 2 episodes of hepatitis or whatever he had. So it tells us that some process is there which is coming episodically. It is not something which is downhill.
Yeah, is it precipitated by something like all these episodes? 3 episodes are associated with?
There was some mild infection, which febrile episodes.
Yeah, so there is some infection which is precipitating it always, or it could be even a stress, or it could just be a mild respiratory URTI, dehydration. Anything can precipitate this underlying condition. Why did it start off in the first place? What could be the cause of a 3-year-old child developing these? Is it something which is congenital or acquired?
Acquired fever. Acquired fever.
Yes, so it is something where these autoantibodies have developed. Nobody ever knows, but we don't investigate also. We try to treat the effect of it rather than going in for what triggered it at 3 years of age. Okay, so the next part is that this child health-wise is normal. If you go to see the health. And that is the first thing where you wanted to rule out whether the liver is involved or it is a non-liver involvement or extra liver, and that's why that whole thing about the gallbladder, etc., all those things came into the picture.
Basically, ma'am, that clay colored stools made us go off track, because in acute hepatocellular environment, there would be any clay colored stools. The extrahepatic biliary apparatus is apparently normal, but the clay colored stools probably told us that there is something which is causing some obstructive phenomena.
Yeah, but now that is known with hepatitis. When you have the acute phase, in that transient phase, you will get white colored stools. So it should not throw you off the track. Just need to follow up them. And then in between the history, the word is there is no persistent clay colored stools. It just happens during that episode, it will go away also. So this is all what has to come out of it. Is there a hemolytic part of it? Because when this child is...
No, HB is normal. No, the child is not having a failure to thrive. Like there's no fatigability, there's no transfusions, child is not pale, doctor's child. So less likely that there's anemia in the child.
Yeah. The only condition which intermittently will come with jaundice like this, and if they are mild variants, then sickle is to be kept in mind. Sickle thal over there, where because of the recurrent sickling, by around 5-6 years of age, the spleen will go away. So when you look at the differential, you have to keep the hematological also in mind with there also. You will get these hepatic involvements which are transient, they go away. Okay, so that is the other part which is there. But otherwise, on the whole, when you go to examine, you found that there was mild hepatomegaly and no spleen. But jaundice, and the jaundice was resolving, isn't it, Dr. Izzar?
Yeah.
The jaundice was resolving. So whatever was happening is transient and it is going away, everything is fine. But it is recurring, and that's why very rightly in these patients, you do need to document. It is basically for the parents to understand, and your counseling becomes very important, especially the doctor's the doctor may not like your diagnosis. They will go doctor shopping and try to find who will give them a better diagnosis, which they wanted. So always document, especially with neonatal, not neonatal, the autoimmune hepatitis, because the long-term follow-up prognosis, everything is required. And I would rather have the diagnosis as a doctor to look after the child all along. So that is the second important part which is there. And of course, we were always taught that when you have unexplained jaundice, rule out Wilson's. So Wilson's is one disease when if the examiner keeps on asking you what else, just say Wilson's, they will shut up then. Okay, the same thing applies to neurology. If there is a dystonia or unexplained neurological thing, just in the end, as a last resort, say, I would like to rule out Wilson's. So Wilson's can present almost all systems involved. Okay? So that is one condition where you need to keep that in mind. In this particular child, Dr. Izzar, I just wanted to know, when they kept on coming repeatedly, was it precipitated? Like, where are they from? Like, is it a local infection in the area where they are coming from? Which part of the state they are from?
They're from Bid only, Ambejogai.
It's a Bid Ambejogai. Okay, because there is a lot of underlying undiagnosed genetic predispositions for these type of autoimmune hepatitis. We don't spend money on that, but it is worth looking into, because I have worked in Ambejogai, though it was for a short time for MCI purpose. But I used to see in the OPD a lot of genetic predisposition disorders. Okay, so if they are from that particular area, that's something familial you need to keep in mind. Is it something familial, which is the underlying, and on that it is getting precipitated by stress or infections, especially malaria, which is there from those parts? Okay. I think so. Overall, it was an excellent approach to the case, and you did the job of the expert. Okay, you didn't leave.
He's an expert
for me. Right. So thank you very much. I hand over to Dr. Sunita.
Thank you.
Thank you,
Dr.
ma'am. Thank you so much, all the panelists and Izhar sir for the excellent case.
Yeah,
So,
I am more than happy that I had to present that to my JR, whom I taught ABC of pediatrics. And
Thank you, sir. Thank you.
Fortunately, actually, I'm very happy that actually is not rusted.
Oh, I was scared. I couldn't sleep last night because I have to answer it to Dr. Izhar sir, and I have known him since long time.
No, we are from JJ. We are not supposed to read. We are supposed to work in the world. We know everything.
It was excellent learning from Dr. Izhar sir and Kinikar madam. It is always great to have JJites around. It's a bond which is there with Dr. Amdekar sir also, and he has told us how to think about a patient. And I'm really proud, and I'm really happy to have all of you over here. Thank you, thanks a lot, sir.
Thank you so much. So thank you, Kinikar ma'am, for being there and enlightening us for so much. And so we end the session, and I request Dr. Jay Bhandarkar sir to give the vote of thanks.
Thank you, Shilpa and Dr. Sunita, for involving this case challenge session. Thank you also our main expert, Dr. Kinikar madam, for presenting in this session, and such a lovely audience here. And learning from is a great, I think, great event as such. And thanks our moderator, Dr. Izhar sir and Dr. Joshi sir. They present so well, and so that given so much, I can say, hints to the case challenger to crack the case as well as go to the diagnosis. And thank you for both the teams from Sholapur and this Nashik. They played very well, I can say. And both cases are to the liver, or I can say, a multi-systemic disorder like cases. And thanks to the expert again. This pahili history is important. So from history, you should diagnose the case and go move forward. And I thank all audience who are present in a large number from since within 5 minutes. Our quorum was full. So thank you very much for attending Mahaiap. But see that you attend all sessions of Mahaiap. They are very, very wonderful. Next Friday we are coming. No, if you want to academically good, you should be in health. You should be also good. So next time we are blessed with the Mahaiap Katta. Dr. Praveen Gaikwad is an ultra marathon runner, and we are going to take interview of him and how he manages all these marathons, all his sports activity. So remain fit at his age of 60. So thank you all of you for joining this beautiful session, and thank you Mohite sir for this wonderful idea. And we all please come with beautiful ideas, contacts on the Mahaiap dice. We can very well do so that we can be number one in the central IP level, Maharashtra. I say last time we were the second. This time we're going to be first. We are aiming for that. Yes, that is a number I can say, but rather we can just engage all of these academic activities and enjoy the academics is the best. So happy Holi. I think we started on the wonderful colors, and we ending this today's our day with wonderful cases and colorful case and colorful discussion. Thank you. Dr. Amol is there. You want to say anything? Still is in the plane. Right. Okay. Good night. Thank you. Bye bye.
Nothing much. The plane is starting now. It was nice to see Kinikar ma'am and keeping phone off.
इस तरह बांधी जाती है। कसने के लिए इस तरह और पेटी खोलने के लिए आप उठाइए और दोनों सिरों को अलग कर।
Thank you very much.
Now plane is taking off.
Right instruction.
We should take off the session also. Thank you.
Thank
Good
you, madam.